Thank you for joining us for the second annual Global Summit, Global Kidney Innovations, Expanding Patient Choices and Outcome, a collaborative partnership event presented by the American Association of Kidney Patients and the George Washington University School of Medicine and Health Sciences. I'm Ed Hickey. I'm an attorney and a Marine Corps veteran. I have managed kidney disease for 5 years as a chronic kidney disease patient and also as a caregiver. I'm honored to serve as AAKP Secretary and a member of the Board of Directors, and also as Chair of the Veterans Health Initiative. It's my privilege to serve alongside such dedicated people who advocate on behalf of patients up on Capitol Hill and in the executive branch. Today, I'm pleased to introduce Dr. Stephen Fadem from the Baylor College of Medicine, who will present on coronavirus observations of healthcare systems responses to the pandemic, both nonprofit and private, and also the VA. Dr. Fadem?
Hello, I'm Dr. Fadem, and I'm here on behalf of the American Association of Kidney Patients, and I am very pleased to be speaking today. Today, I will be speaking on observations of healthcare systems responses to the pandemic. As you are all aware, the coronavirus has taken over and has been dominating our lives. Currently, there have been 13,119,939 cases with 573,752 cases. This has led to a case fatality rate of 4.373%. We have about 154,000 new cases a day. In the United States, we have had 3,363,056 cases and 135,605 deaths. And our case fatality rate is 4%. I live in Texas, so I will be addressing some of the issues that are pertinent to where I live. We have had 281,000 cases with 3,378 cases. And right now we have a very low case fatality rate of 1.2%. And in our county, where Houston is, we have had 49,027 cases, 473 deaths, with a case fatality rate of only 0.96%. My comments will be pretty much limited to the Texas Medical Center. This is an area which is around 2.1 square miles, but it extends outward for several miles and is located in the heart of Houston. It includes major hospitals such as Houston Methodist, Memorial Hermann, St. Luke's, and MD Anderson, as well as the Michael DeBakey Veterans Administration Medical Center, which is nearby. We have two major universities, Baylor College of Medicine and the University of Texas Health Science Center. Also, Weill Cornell University has a satellite, and they affiliate with Methodist Hospital. Our medical center employs 106,000 people. A surgery is performed here every 3 minutes and a baby delivered every 20 minutes. We have 160,000 visitors a day coming in and out of what is purportedly the world's largest medical center. Also, I'm very proud of my service to the Veterans Administration. As a professor, a clinical professor at Baylor, I have the privilege of teaching at the VA hospital. Here we care for 113,000 veterans with 5,400 employees. The Veterans Hospital in Houston, and I do want to clarify that I do not speak on behalf of the Veterans Hospital or Baylor College of Medicine or any other entity with which I'm affiliated. My opinions are my own, but no doubt I my opinions are very, very high when it comes to the medical center and to the Veterans Hospital. We have had 805 cases, and since the disease started, we've had 23 deaths. We have a case fatality rate of 2.86%. 80 patients are currently in the VA hospital that are COVID-19 positive. There have been 2 deaths among our veterans employees, although it is not clear that they actually got the disease in the hospital. It's quite likely that they got the disease elsewhere, as that seems to be the case. And that is because entrance into the hospital is very, very strictly monitored. Nobody can come into the hospital without first attesting to their health and whether or not they've been exposed to the disease. They have to sanitize their hands, and they have to have their temperature taken with an infrared thermometer. Everybody has their temperature taken. And the other thing that we do, which is really wonderful, and this pretty much catapulted telehealth, is that we're very big on telehealth at the VA hospital, as we are all over the medical center. The Texas Medical Center has 1,330 ICU beds. These are stage 1 or phase 1 beds. These are the beds that we use on a regular basis. In a crisis situation, such as overflowing these beds, because we have a lot of patients now in the ICUs that have COVID-19, we can add 373 additional beds. And then our phase 3 is 504 additional beds, which we can find around the hospitals. We don't expect that within the next 2 weeks, but it certainly is a possibility. So we do have a surge plan in place. And so we do have a total bed capacity of 2,207 beds. Right now, the Texas Medical Center has 2,331 positive COVID-19 patients, with 651 of the patients in the ICUs. Houston has 1,360 new cases each day. Right now, we're 6% into phase 2, but hopefully we will be okay. That's why we want everybody in our city to use Perel, sanitize, and we also want them to use a mask. Even a designer mask, like a Gucci mask, will work. What are the takeaways right now, the last 48 hours, from our experiences here? First of all, we've had 1,582 people who were reported testing positive just in the last day. We get about 1,776 new cases a day. And this is 4 times what we observed in our previous peak, which was on April 6th. And this was after we opened up. We had Memorial Day. We had people going to the beaches. We had people going back to the malls, back to restaurants, back to bars, protests, and everybody pretty much acted like it was a normal day in Houston. Most people did wear a mask, but a lot of people didn't. Most of the people that didn't wear masks and that were traveling about were younger people. And as a consequence, we are now one of the highest rates in the nation for new COVID cases. Yesterday, we had 247 new COVID-19 patients hospitalized at Texas Medical Center institutions. And the average daily for the week was 101. The confirmed new cases can be affected by the level of testing, yet hospitalizations have represented a more absolute indicator of the COVID-19 prevalence. In other words, many patients will test, but many of those tests will be negative. So the ones that are positive that end up coming to the hospital are the ones that we have to worry about. As I mentioned, our capacity is okay. We are in phase 1 and 6% into phase 2. I think we'll be okay within the next 2 weeks, but we'll see. What is the overview of what's going on in Houston? Well, as I mentioned, we have 3 phases of ICU care, and this is what's most critical for taking care of patients. Because when you have a patient who is short of breath and they have pneumonia, the only way you might be able to take care of them is by intubating them, putting them on a ventilator, and essentially taking over their respiratory functions until the disease has a chance to improve. And the only way to do that is in a critical care unit where you can monitor the patient very, very closely and put them on an assisted ventilation machine called a ventilator. And so that's why the number of ventilators and the number of beds and the number of nurses is critical. The problem right now in Houston is that we don't have enough nurses, and we have a nursing shortage. The military has sent in some reserves, and they are helping throughout the city. We're very grateful for them. And it is a problem because of our nursing shortage. Houston Methodist has had 11,358 cases and 209 deaths, which is a low case fatality rate of 1.84%. There are 716 patients currently in all of the Methodist hospitals, not just our medical center hospital, but some of the hospitals that ring the city. And the Houston Methodist hospital system has 2,264 beds. 924 are in the medical center. Elective surgeries have slowed down, but they have not canceled. In other words, our surgeons are still doing things like arterial venous fistulas and hernia repairs and gallbladder repairs, and of course emergency surgeries that are also needed. But one of the things that we've done to take the load off is that we have had extensive telehealth encounters. And this has really made a difference in how we've been able to take care of patients. So what do we tell our employees? And we want our employees to be ambassadors for the good health that we're providing. So Baylor College of Medicine, which is one of the premier medical schools in the country, has developed a 10-point program. Number 1, continue to conduct daily health checks where we ask patients and employees and our doctors and each other if we've had any symptoms or if we've run temperature. We require our employees to wear a face covering in the workplace if appropriate, and as well, we now require it outside the workplace because we don't want we want no community exposure. So our employees are required, in fact, everyone in the city is required to wear a face mask. In the hospital, we now require a face shield. These shields are very important because they've been shown to, number 1, not be uncomfortable. They're actually comfortable to wear, and they do a really good job of keeping the virus away from us and also keeping us from touching our mask and fidgeting with our faces. And so the shields are also good. We want to minimize face-to-face contact between each other, our employees. And so when we eat, we usually don't face each other directly. We eat at an angle, and we try to eat spaced apart. and we try to minimize our food content. And when we can, we like to take our cappuccinos and stuff back to our desks so that we're not eating and drinking too much in front of other people. We want to evaluate if any of our employees are coming from outside the local areas. There hasn't been a lot of travel, and there hasn't been a lot of airline travel, but it's always good to know if somebody's been to an area where the disease is worse than it is where we are. We want to limit our meetings in conference rooms, so we will use conference calls whenever possible. The nice thing is that we can use Zoom and WebEx and what have you from a cell phone. And it makes it very convenient when we don't have our computers in front of us. And we also want to limit the number of people that are in the rooms. We like to space out, ensure that nobody's within 6 feet. And we want to stagger the gathering times when shifts start, when we eat lunch. And if employees are symptomatic, if they have a cough, if they have fever, if they don't feel well, then we want them to stay home. If they feel up to it, they can certainly work from home. But the important thing is that they stay home and get well and not spread the disease. And then we try to avoid confined shared spaces for prolonged periods of time. Of course, the most confined shared space is an elevator. So we try to space ourselves in the elevators as well. So what is the point of entry? First of all, an attestation. At Baylor and at the VA, these are electronic. You fill out a little form online, and it's charted and recorded, and you now have a contact of yourself. The infrared temperature checks are really a phenomenal way that we can identify quickly who's sick. I actually have several of these at home and at work, and I love making sure that nobody around me has temperature. And the other thing that's critical is sanitizing. Wash your hands, keep your hands as clean as you can, because the bugs can live on your hands. They can live on elevator buttons, things that we call fomites. And why take that risk? We all wear PPEs, a procedure mask, the gowns in our dialysis, and of course our ICU areas, and our face shields. And in the areas where we actually deal with patients, we have a helmet that we wear. And we extensively gown and don our gowns in a very special way. And in the areas where we're dealing with patients, we wear an N95 mask. Now, an N95 mask looks a little bit different. It has to be fitted properly. And we usually don't wear those during the day. We wear these nice, comfortable procedure masks. These are official surgical procedure masks. They also will protect 95% of the viruses from getting across. They don't protect us as much as they protect other people. But by protecting another person, if everybody wears one, then everyone is protected. And we are very interested in universal pandemic protection. That means patients and healthcare workers and doctors and everyone else needs to be tested. Whether you're asymptomatic or symptomatic, we need to test so that we know what's going on. So this is what it looks like with testing. And this is how it looks at Baylor, where on a surveillance level, of course, you'll notice that most of the people have been positive and have been negative, rather. And so we had very, very few people that we tested in surveillance that were positive. And the surveillance testing was where people had been voluntarily testing. The Sentinel testing is a volunteer testing program. And in that program, we only had one person that was totally asymptomatic that randomly tested that was positive. However, in the symptomatic program, we had 235 people that are positive. So while asymptomatic people can transmit the disease, in our experience, of course, it's much more common in the symptomatic patients. And the first sign of a symptom is a loss of smell. And so you'll notice that in your kitchen. And but then another sign is fever. So that's why it's very important that we take temperatures. Face shields. These are wonderful. They're now required in the hospital, and this is a CDC requirement. I have my personal one with my name on it. You can use it, or you have to use it really, with a mask in the hospital. It's very easy to take it on and take it off. It's comfortable. It's extremely inexpensive. And because of this giant foam padding in here, you don't really need to fit test it. Historically, we didn't discover this yesterday. This was all discovered years ago. In 1918, Joseph A. Capps published a paper in the Journal of the American Medical Association, and he noted the value of prevention control at military camps with wearing masks and social distancing. The problem is that because it was military and because we were trying to fight World War I, the non-medical people in the military ignored him and said, "Oh, we don't have time for your ideas." And as a consequence, the disease spread and spread and spread. It spread so that 675,000 people in the United States died of influenza back in the Spanish flu epidemic of 1918. And so we're dealing with literature that's over 100 years old. In fact, this study was stopped because the equivalent of the Data Safety Monitoring Board at the time said, it's a waste of time continuing with this study. We already know that it's a good study. So you can see that we've had precedent for wearing masks. The procedure mask is simple to wear. It's comfortable. It can be used commonly in the hospital. It's very inexpensive, and about a nickel maybe at the most, 7 cents. And you can buy it on Amazon.com now. There was a time when there was a shortage, and that was problematic. But they started making them again and importing them again. The N95 mask. It's not required unless you're in a room where the patient's on a ventilator or you're doing a procedure. It will protect the patient and the worker. It must be fitted. It is, trust me, uncomfortable. And you really are not supposed to reuse it, but reuse is per manufacturer. Special rules were made when we had a shortage. 3M, the major manufacturer, did not make enough of these, and that became a serious problem. And but now they are making them again. So this is a complicated study, but it shows that a lot of the N95 masks don't work because they fail. They don't fail except they don't fit right. And a mask that doesn't fit right is like not wearing a mask at all, because the germs can go around the side. And so it doesn't protect you like it's supposed to. And you can see that in healthcare workers, there was about a 20%, there was a 74% fit pass rate among nurses. Nurses did better than doctors, as you would expect. They had about a 25%, 26% failure rate where their masks didn't fit right. And doctors, we were pretty bad at 36%. So the length of time that you wear the mask also makes a difference. If you wear the mask for a long period of time, you have a more likely chance of it failing. So this is something to keep in mind. For the most part around the hospital, unless we're working in the ICUs, we just wear these nice, comfortable procedure masks. So let's have a wrap up. First of all, there's a vaccine coming. Moderna is promising 100 million doses within a few months. They're promising us 1 billion doses a year. There's an inhaled version of remdesivir for less severe cases, and clinical trials are starting on that. Remdesivir is very effective in helping to treat patients with COVID-19. The hospitals are smart because they're starting to stockpile drugs. They're trying to get a surge for at least 1 month and some for 2 months. There's a big debate on school openings. I err on the side of caution, and I'll be happy to debate that with anybody. I think that an aggressive COVID-19 vaccine trial is going to happen very soon, and we're going to see the vaccine hopefully within the next year. That should put this whole thing to rest. And there's also a rapid test in development that'll cost about $25, and right now it's about $200. And if it's rapid, and if it's accurate, and if it's cheap, then we can increase testing even more, which means we can isolate people and contact trace and keep the people that are infected away from everyone else. I just want to say one thing about telehealth. It's been used extensively. We use it in our homes. We use it at the VA. The Alex Azar, who's very pro-health, is very pro-telehealth. So is Seema. So is Deborah. All of the leadership at CMS and in Baltimore and in Washington are very much in favor of telehealth. It works. And it's not cheaper because we still have to put time in, but it's better for the patients. They don't have to drive all the way in, and sick people don't have to get out of the house. You don't have to be risking an infection or infecting someone else. And you can spend the time talking to the patients. I do miss the hands-on. I miss the stethoscope. But we can do it when maybe less frequently in the future. Or we can, the doctor or the nurse can start making house calls. We might see house calls becoming more popular in the future. It still is going to take the same amount of time. Some patients are not computer savvy, and for that we use the telephone or we use FaceTime. Or if they're fortunate enough to have a 4-year-old grandchild in the house, they can help them with it. I also want to say that the VA is very pro telehealth. They are leaders in this and leaders in real-time video. And at the VA, it has become very, very practical. The VA has just announced on Tuesday a big study that they're going to be doing on COVID-19. And this is a study on tocilizumab and tocilizumab. And tocilizumab is an excellent treatment for pneumonia. It will help to reduce the inflammation, and it shows great promise. So you're going to see this study for tocilizumab begin at the VA hospital in Houston. I want to thank you for participating in this conference. It was a privilege getting to speak to you today on behalf of the American Association of Kidney Patients.
We appreciate Dr. Fadem for taking time out of his busy day to share his insights on medical research and the coronavirus and how timely research and innovation can improve patients' lives and society. Thank you, Dr. Fadem.